Greetings. We'll get started in just a couple minutes. We're just doing a sound check.
It's good. Is it good?
We have to wait until.
You ready to go?
We're good.
Okay, hello everyone. My name is Jeff Hull. I'm the director of Lowell Observatory here in Flagstaff, Arizona. A couple of weeks ago, I reached out to Dave Engelthaler at the Translational Genomics Research Institute, their branch here in Flagstaff. He's the director of that facility, and they are on the front lines of the COVID-19 situation, with the idea of having him come here for a briefing as a resource for our staff. Like everybody in the couple weeks since, we've gone virtual, and since we were going to stream this anyway, we thought it would be good to offer it as a resource for the community. So we're going to stream for about an hour. Dave's presentation will be about 30 minutes, and then we will take 30 minutes of Q&A. We have a few people in the room because we're restricting our meeting sizes these days. We'll take questions in on the chat stream to the right of your streaming window. Thank you very much for joining us, and a huge thanks to Dr. Engelthaler for taking time out of what is a very busy point in his life to give us this excellent information today. Dave.
Thank you, Jeff. Good day, everybody. Thank you, Dr. Hall, for inviting me. It's a pleasure to come out here to Lowell and speak with the friends of Lowell and staff and members of the Lowell family. Today's a busy day. We're going to talk about COVID-19, which is this novel coronavirus that everybody should know about and probably knows quite a bit about. What I want to do is discuss a little bit about the virus, a little bit about the disease, and about the overall response and the state of things right now. I am a associate professor at the Translational Genomics Research Institute. We are a nonprofit research institute located here in Flagstaff, Arizona. Our focus is using genomics to solve infectious disease problems. And of course, this is right up our alley. I'll talk a little bit about TGen and our overall part of the response as well. But I really do want to go ahead and jump into the disease, and we'll start off with kind of the state of things today. Now, this is a little bit unusual. We're doing this streaming, so I'm going to be pointing things out on the screen, and hopefully you guys can zoom in if needed. I'm also going to be showing you images and pictures that come from a variety of sources. Hopefully most of those are credited. If not, that's completely my fault. But for instance, one of the great ways to track this disease and the virus is through the Johns Hopkins Coronavirus Resource Center, and they update this by the minute. And so these are numbers from today, the overall number of diseases, and as well as tracking the total number of deaths around the world. In this particular view, what we're looking at is where all the active cases are. So when you looked at this a month ago, almost all the activity was in China. We're seeing significant activity now in Europe as well as in the Western Hemisphere, mostly in North America and primarily in the US. About 230,000 cases total detected to date around the world, and that number keeps climbing obviously by the minute. 9,300 deaths. When we zoom in and look specifically at the US, in this particular frame, you don't see these big giant red circles, but it is showing us where we're seeing activity. In reality, we see activity in all 50 states, and I think in all US territories. 10,755 cases confirmed as of this morning on March 19th, 154 deaths. And then if we look in Arizona, where we're located, I know we have viewers outside of Arizona, the numbers this morning, total numbers reported in Arizona, we're at 44. This is actually just north of 50. That number is going to keep climbing, just like the US numbers are going to keep climbing. And we should not be overly alarmed about the large increase in numbers that we're going to see, because we're really doing a lot of testing now. Now we're going to find those cases that had been here probably for the last several weeks. We know actually, for instance, in Coconino County, there's at least 4 cases and that's going to continue to go up, and that's where Flagstaff is, and that's where Lowell Observatory is as well. One of the things that was on the Johns Hopkins screen that down at the bottom that I wanted to point out is this particular graph, and I'll try not to get too much into data and too much into science. We'll get a little bit of that and a little bit, and try to step back a little bit. But this to me is very interesting, is actually somewhat encouraging news, and we're going to see different types of this evidence. What we see on this screen is we're looking at the daily count starting back we're going back here to just before January, so the end of December when the first cases were happening. The orange dotted line is registering the number of cases, and so if you can't see on your screen, this dotted line across is 50,000, this is 100,000. The orange dotted cases those are cases in China. And what's happened is that the total case count has leveled off in China. We are only seeing relatively few cases every day now in China. That means China has really, if not run the course of their outbreak, at least they've stabilized, and it's definitely on the downswing. So we're not seeing active new cases increasing in China anymore, and we haven't for quite some time, since some part in February. The yellow dots along the bottom that are now skyrocketing up is pretty much everything outside of China. Most of this is Europe and the US right now. But the good news is that it ends. In China, the impact is ending, or at least coming to an end to, maybe it's the season, and maybe we're going to be seasonal. We'll talk a little bit more about that. We're not there yet in the US. We're really just getting started. There is light at the end of this tunnel. We're just going into a dark tunnel, and it's going to feel like that for a while. But by looking at China and looking at South Korea and other places that have already been impacted, they're on the decrease, and that will happen here too. In fact, one of the great pieces of news that I just read yesterday is that all 42 Apple stores in China have now reopened. So this is a good sign that everything is starting to come back to, if not normal, back to some semblance of normalcy. We will get there as well. Here's another look. This is from the WHO. When we look at total case counts, here's the China outbreak. We had just an enormous number of cases reported in an individual day, but that was because it was catching up from cases that had been missed before. But this is about February 17th, February 19th, when the outbreak is really starting to subside in China. Here is the rest of the world. The peach color here is Europe. The Americas are the yellow, so very little in the last few weeks, and now it's starting to take off. So the rest of the world curve, what we call an epidemic curve, is going to take off, but it'll also come back down. Okay, let's talk about the virus a little bit. The COVID-19 virus is called SARS-CoV-2. That's the official name of this virus. There's a reason for that. It's in the SARS coronavirus family, and I'm going to point out that here in a second. But this type of a virus, it's an RNA virus. That means that the genome can replicate fairly easily. It's not DNA, but it also replicates with errors in it. And that's what allows for mutations to occur. As this is spreading around the world, we're seeing these mutations happening. That genome encodes for a few different proteins, and one of those is the protein that causes what look like spikes on the outside of the virus. And those spikes cause this crown effect, and that's where coronavirus comes from, corona meaning crown. So that's the type of virus that we're working with here. This is a zoonotic virus. That means it came out of animals. There's no doubt about it. This is likely bat origin. I'll show you some more on that here in a minute. And it is now becoming adapted to humans. And in fact, it targets the same human cell proteins, the same receptors for the virus that it does in bats. And it's the same receptors that the SARS virus back in 2002, 2003 targeted. That's why it's become easily adapted to us. Most animal viruses won't be adapted to us. This particular one has become adapted to us only because it was already adapted to very similar cell proteins that they find in bats. Now this one might be a little tough to see. I don't know if you can zoom in on this. But this is a family tree of coronaviruses, and this is just important for us to understand where this virus came from. A lot of discussion about where the virus came from. Was it out of a lab? Did it come out of nature? It absolutely came out of nature. What we're seeing is this is one group of coronaviruses that includes all the SARS viruses and a couple of the human strains as well. What we see in this red lettering, this is all the initial strains of this new SARS-CoV-2 virus that was found in China. And when we look at branching on a tree like this, that's what tells us whether or not things are closely related. So the closer the branches, the closer your family members are in a family tree. Same thing here. So this is very closely related to a couple of strains of other what we call SARS-like bat coronaviruses. Definitely came out of bats. In fact, this entire group came out of bats, including up at the top here in red is the original SARS virus that was from 2003. So we can see how pretty closely related these all are, and these are all out of bats, well adapted to bats. There is no doubt that this virus also came out of bats. But it's possible it got into other animals before it got into humans. We don't know that part yet. We know that it's possible it came out of these Chinese markets where they sell live animals for food, and those animals can share viruses very easily. They do all the time. That's why we see a lot of new things coming out of that part of the world, a lot of new viruses. We also have down here MERS, which people have talked about. That's the one that's the Middle Eastern Respiratory Syndrome virus. Very, highly fatal, not easily spread between people. Mostly found now in camels. And then down at the bottom, there's another red line here. That's two red lines. Those are the human coronaviruses. You can see those branches are really long, separated from everything else here. These are well adapted to humans. It's what we have the common cold, easily spread between people, not fatal at all. Okay, COVID-19, and just to remind folks, and I didn't mention this up front, after this part of the presentation, we are going to do Q&A session, so we all already know that questions are coming in and using the chat feature. Go ahead and send in questions, because I can't answer them as we go along. I'd really love to, but we will certainly get to them. So a little bit of overview about what we know about the disease and the virus. This virus is a brand new coronavirus, but only brand new to us. It has been around likely for a very long time, eons living in bat populations. It acts like the common cold and flu. It's found in the upper respiratory tract as well as in the lower respiratory tract. So it can be easily spread, coughed, sneezed, and infect other people. That is not the case with the other coronaviruses like SARS or MERS. Those are harder typically to spread, and they don't last as long in human communities. The virus, we're learning more and more. How stable is it? There's a lot of discussion about this. There have been empirical studies to show that the virus, at worst, is viable up to 72 hours on certain surfaces. Now, it is more stable and can survive longer on plastics and on stainless steel. That means those types of things that are in common areas we have to wipe down a lot to kill the virus. It can last for hours. Most likely in the natural world, not up to 72 hours, but several hours. Less likely on copper and cardboard, does not survive very well, becomes desiccated and dies. But it is important to know that it can survive. That's why we have to continue to maintain clean environments, constant wiping down with Clorox wipes and the like. Most people in China during that first large outbreak had mild disease. So over 80% of individuals had mild disease, which was more like somewhere between a common cold and the flu. You feel yucky, the cough, the fever, and maybe even a walking pneumonia, but most people survived and got through that just fine. Similar to influenza, some people are at much higher risk for complication, and this is really important. These are the individuals that we have to focus our energy and efforts on to help them through once they get infected using best medical care. That's over 65, but especially over 80. 80% of the deaths in the US so far are people over 80. So this is a really important group that there's a lot of energy and focus on. And this is where we're going to be most devastated, is this part of our population. We really have to do everything we can to not spread to them, and then do everything we can to support medically these individuals. Underlying medical conditions are also important. Diabetes, heart, and lung disease, these are the ones that have been seen as the most important. We don't have a lot of information yet on immune suppression. We think that immune suppressed populations are also at risk, so HIV infected, and that's really going to hit certain parts of the world hard, especially in the southern hemisphere, once they start seeing more disease. Symptoms, as I mentioned, these are the symptoms: fever, cough, shortness of breath. So it's actually affecting the lung You may be getting pneumonia, you may have chest pain. This is really like a serious flu type symptoms. Certainly, if you've been exposed, known you've been exposed to someone with coronavirus or been in those areas where there's a lot of circulating virus, these are the things to look for, and certainly call your healthcare provider if you have these symptoms. They will be able to direct. Don't just show up at the doctor's office either, and don't just show up at testing centers that are starting to pop up everywhere. You have to work within the healthcare system. You can get doctor's orders to go get tested if you fit the right criteria. And the purpose of having criteria around this for people to get tested is so that we don't completely use up all the tests on people that don't need to be tested, and that is critical. There is not just a shortage of the CDC tests, we're beyond that. There's tests out everywhere, but there's a shortage of everything else that's necessary. The little test kits, the swabs, the personal protective equipment of the people doing the tests, all of that's important. We don't want to use that up on people who don't need testing, so it's still important to work within the healthcare system. So what else about COVID-19? It spreads easily through respiratory droplets when a person coughs or sneezes. This is where we talk about the social distancing. You've heard about 6 feet. That's my wingspan. That's the typical distance. That you go beyond that, you're going to not likely be able to spread a droplet out that far. When you cough and sneeze, lots of microscopic droplets do get expelled out, and those could contain virus. So this is the thought right now. Beyond 6 feet, you're most likely in a fairly safe zone if you have people separated that far. It is spread through that close contact, and typically where there's a lot of people gathered in the same space. People are most contagious when they are most symptomatic. There's been a lot of discussion about asymptomatic potential. We do think that there is some spread by people who have mild symptoms or asymptomatic, but that is pretty rare. We think that the vast majority of all spread is when people are most symptomatic, coughing and sneezing, because that's getting the virus out of the body. There have been reported, as I mentioned, cases of the asymptomatic, and this is just not the main way this virus is spread. We don't understand the epidemiology around this yet, the importance of this for causing disease. Now, there's been a lot of discussion about these what we call non-medical interventions. These are what public health has been telling us for months now, since we first heard about this, and some of it sounded trite, but it was all very important. At the bottom, the baseline, hand hygiene and cleaning. Constantly wash your hands with soap and water. This is really important, not just because you might be ill, you don't want to spread it, but you're going to be touching surfaces and other things. You don't want to essentially get your hands contaminated, touch your mouth or your eyes, and potentially cause an exposure that way. Still very important, and more important than ever. We know there's shortages on hand sanitizer. Use those if you have them. More importantly, use soap and water as much as possible. And then cleaning surfaces, Clorox wipes, handles on doors, even in your own house, certainly in businesses, and absolutely in public areas. The next level was self-isolation of sick. So when people are sick, we want them to stay home from work. We want them to stay home from school. Now, a lot of people are staying home from work and school anyways because those are out, but then you still need to isolate yourself from others. If you have symptoms, flu-like symptoms, even if you haven't been tested positive, we just stay away from people. Yet, this is something that's kind of our new normal for right now. Have that ability in your house to stay away from and not have constant interaction with the rest of the family if you are sick. Monitor your contacts. So this is something that public health is doing. Once we identify cases, we need to still keep track of where all the contacts are. We still are in the response mode of dealing with when we get little hot spots. We're trying to slow down the spread, so we try to find those contacts and put them into quarantine. This is the people who are contacts. We want them out of the system, not infecting other individuals. Social distancing, we've talked about. These are this is why bars and businesses and others are closing down. This is not, it just sounds draconian, and it is draconian, but it's really important to slow down the spread of the virus in the community. And we'll talk about that in a second. Community closures, as I talked about, that is now in place and being used. And then in some parts of the world, the cue there is quarantine. That is now not just individual quarantine, but quarantine of cities, neighborhoods, and in some cases even countries. And that's been in place in a couple of spots in Europe. And the whole point here, you're not stopping this disease. The whole point here is to slow down this disease as much as possible. Now, there's been a lot of discussion, not just about social distancing, but the phrase flattening the curve. And I just want to explain that a little bit so that folks get an understanding. When we put in social distancing, it is essentially to turn an epidemic that looks like this, a really sharp peak, to an epidemic that looks like this. You have a much lower peak, it is more spread out. What's true is the number of cases in both of these is exactly the same. We are not lessening the number of cases. What we're trying to do is lessen the number of deaths. And the way we do this is flatten the curve, spread it out, slow the virus down. It gives the community, society, and most importantly, the healthcare system a chance to keep up with the ongoing needs. We have a major epidemic like this, hospitals get shut down, it looks like Italy, and you have a lot more deaths because of it. You have a curve like this, the hospitals can absorb a lot more. Still going to be pretty devastating, but this is, we can already tell that this is happening, the flattening the curve, and that's why we still have to pay attention to these things. We do not want to ignore the recommendations and now some of the mandates that are in place. Okay, the mask question. This is something that came up early on, and we were told not to buy masks. We were told that the masks don't work, so we shouldn't buy masks. Well, we shouldn't buy masks just for our personal use. But masks do work. If they didn't work, healthcare workers wouldn't use them all the time, and they wouldn't tell patients to put them on. But the point of masks, they're best to keep healthcare workers safe and to keep sick people from spreading the virus. So that's why we put a mask on people when they come into a doctor's office, just in case they have it, they won't cough as much and spread it around. The point of not wearing masks is the fact that the N95 masks are really critical for our healthcare workers right now. We didn't want them all purchased up. There are supply chain issues and shortages, and we need the healthcare workers to have the masks, and not individuals walking around with them. I'm not going to tell you that masks don't work, because they do provide some level of protection. It's just we're also hurting our neighbors, our elderly part of our population and others by taking those masks away from the healthcare workers. Surgical masks won't stop infection. We've seen a lot of people walking around with surgical masks. You can breathe through particles on those surgical masks if they're airborne and they're small enough. But it's one of those, it's kind of a comfort thing. People start to do things that at least give them some sense of safety. We just don't want people thinking that they're safe because they're wearing a mask. And then there's makeshift masks. Now, I got to show you a couple of pictures, there is a little bit of levity here. And this is not at all to make fun of people's pain and suffering and anguish. We're all in this together, and our concerns are natural and normal. And when this first started, people were trying to get their hands on any mask that they can make. And so we actually started seeing a lot of makeshift masks. And this is grapefruit actually was very common, and there were instructions online how to make a grapefruit mask. It's not really going to do much for you except give you a nice sense of aroma and somewhat interesting with it. We've seen other ones. For some reason, this is very popular in China, was these water bottle kind of respirators. I'm not sure exactly how they work and why they became so popular, but they started showing up everywhere. And in fact, we saw images of families, and you can see there's lots of people that are wearing these. People maybe got some sense of safety by doing this, and that's good. And if everybody's doing it, then maybe it seems normal, so maybe that's good too. But they're probably not doing a lot for protection overall. And then some we absolutely recommend against. This does not look very safe. We have a family here draped in plastic bags. So once people get worried about things, they start to come up with solutions, and sometimes those solutions may cause more harm than fear. And then even masks started showing up even on Fido. We've heard about pets potentially getting sick from this. There's very, very few cases that have been documented of them being infected. There probably will, and there will be some that actually could get sick, just because, just like humans, animals all have different immune systems, can respond differently. What actually we do know is animals can get infected and actually potentially infect others. So we got to make sure we're not infecting our animals. If you are sick, you got to isolate yourself from your animal. I don't know how well this mask is working around all that facial hair. And in fact, the CDC came out with a facial hair guide for wearing masks. Lots of individuals, you see facial hair will cause problems. And there's some facial hair that you can actually wear with masks. You can find this online in CDC if you want to learn more. So this particular scene just reminded me of, there's a lot about life imitating art, and there's been a lot of movies about disease outbreaks and pandemics in the past. One of those more recently was the movie TGen, which actually has a lot of things that we're starting to see. You know, these makeshift respirators, that was part of the situation. Jude Law here in a interesting outfit. And just a very normal thing. We're seeing that people are coming up with their own respirators. Now this image is very blurry. I realized I grabbed the wrong one. But in this particular instance, this character came up, or at least was hawking fake medicine. In this case, forsythia, if anybody's seen the movie and remembers that, provided no protection whatsoever. But people start selling snake oil online because they know everybody else is afraid and they're going to pay money. And this is certainly another real problem with a disaster like this. This forsythia, I actually saw the Forsythia Festival last week. Actually, there is a festival every year called the Forsythia Festival. It got canceled due to coronavirus, which I thought was kind of ironic. But we do still see there are remedies online out there for coronavirus. None of these are tested. Hopefully they're not harmful and they don't hurt you, but they're probably not going to provide any help either. We don't know. And there are plenty. This is actually a legislator in India who had sent this out, talking about the utility of cow urine and cow dung as a treatment. Again, it's not just, it's people in the know that actually may be spreading false information as well. We'll talk about that here in a second about what we can do. R naught. This is that R net zero. That's become popular in discussions in the media as well. And that was a big part of the movie TGen, where the lady from Titanic was telling us how to calculate the R naught for different organisms, and that has certainly been the case in a number of discussions about R naught for this SARS-CoV-2, and it acts a lot like the flu. We're going to get about 2 to 3 people infected for every one individual as the outbreak continues to increase. Social distancing is to help knock that down, maybe below 2 and hopefully closer to 1 for spread. But also, the more people get infected, the more immunity you have, the less opportunity the virus has to spread around too. So by the end of an epidemic, that R naught value starts to drop significantly as well. Some other viruses, measles, that's the preeminent spreading virus, 11 to 18 cases for every 1 individual. So those are sky high. This is something that we see with influenza as well. And then there was a discussion on super spreaders. When SARS came out, super spreaders was a real big issue. You had 1 individual infecting up to 40 or 50 other individuals. We have seen a little bit of that. This particular famous case of a individual from Singapore traveling to a ski resort, I believe in France, infecting a large number of people. Then those people went back to different countries and caused more infections as well. So this is a phenomenon that we're looking at with this virus as well. Also in TGen, there was the obligatory red map, the spread of the disease. That is, we've seen these maps too. Here's the Johns Hopkins map. This is really zoomed in, but we still see that effect. And there's a lot of truth in some of Hollywood movies, particularly TGen. The other ones, maybe not so much. The empty shelves scene, we see this too. Absolutely, we're seeing this around the world. I was in Sam's Club last weekend. This was definitely exactly what the toilet paper aisle looked like. We know that this is happening. It's a very natural human response to try to go out and buy what you think you need, way more beyond than what you probably do. And if somebody's buying something, we need that too, and that's why we now have a shortage of toilet paper. And then the last thing I wanted to point out was the bat connection. In that movie, spoiler alert, that was clearly a virus coming out of bats, went through another animal and into humans, and that's absolutely what's happening here. This is the horseshoe bat in China. It is the carrier for a number of these bat SARS-like viruses. Most likely is going to be the host or similar to the host or the reservoir for this virus, where it probably lives normal and natural. Maybe causes the cold in the bats. Okay, to mention on TGen, we're a nonprofit research lab. We also see ourselves as genomic first responders. We're actually able to use next generation science and technology, not to just study these organisms, but to respond when bad things happen. We've been doing this for years here in Arizona, as well as nationally and internationally. We've participated in dozens of disease outbreaks, some of the largest ones in the past 10 years around the world. We helped CDC develop their own genomic capacity over the past 8 years. 8 years ago, they were about the same level as we are now. They are the preeminent public health genomic entity in the world. We've supported Arizona during the previous pandemic, the swine flu pandemic. We found the first cases in Arizona during that particular instance because the CDC didn't have enough testing to go around and it was a backlog, very familiar or very similar to the current situation. We've also been involved with biodefense projects and developed technologies that we put out into hospitals and into health departments. And now we're responding to coronavirus. So one more slide on TGen. Our community, we do have a genomic response on multiple different levels. We've been engaged in community screening, looking for circulating virus out there in the community, working with the Arizona Health Department and a number of healthcare institutions. We've developed diagnostic tests just like the CDC test, but now we can also do hundreds to thousands of samples a week to support the overall response. We've stood up a diagnostic lab, what we call a CLIA level lab, and are actively part of that overall response and working actually with multiple states too. We actually just found the first 4 positive cases in Coconino County. We've been developing additional assays and technology, including blood tests. We're going to need more technologies as we try to understand this outbreak, as people start to get immune. We want to understand what that is and looking at antibodies. We're working on that. We also have some early stage drug development work. So we're hitting multiple prong, but we're also working with the entirety of the biotech sector. Now your response, and I'm going to probably go maybe 5 minutes longer than my originally planned because I think it's really important for everybody to think about, okay, great, that's what everybody else is doing, that's what the scientists are doing, this is what government's telling us, what can I do? Well, I think every one of us needs to have these 3 things in mind: education, perspective, and action. I'm just going to talk about how I see each of these things. So education, we absolutely need to stay informed. In order to make good decisions for ourselves and for our families and for our communities, get your information from trusted sources. There's really good information out there. The government websites, in this particular case, are really good. Some of them may be a day behind, but it's only a day behind. They're getting out as much good information as possible. The CDC, WHO, Arizona Department of Health Services, or whatever state you may be in, providing out as much updated information as possible. The Johns Hopkins website, some of the big medical journals, Lancet, and others, and New England Journal of Medicine are putting out great updated information, open source to everybody. That's a great place to get information. Don't get your information about this from political sources. CNN, Fox, that's where a lot of people are getting their political news because everybody thinks that's what the news is now. It's not a good place to get coronavirus stuff because it is all tinted in one direction or another, and it's not useful information. It's just, they've picked up a way to how to carry on the fight they've been having for a long time. Get your information from trusted sources. When stuff is out there on social media, question everything. You should anyways. In this particular case, it's just too easy to pass along or to see stuff that really isn't true, and it's interesting. So don't pass along the exciting and the scary stuff because if it's not well vetted, all you're doing is amping up the amount of concern and panic and how people are feeling high anxiety right now. Most of that stuff is fake anyways. It's really hard for individuals who aren't deep into the science and the epidemiology to understand what's real and what isn't. Perspective. Now this is one way to think about this. This is not downplaying this outbreak at all. But imagine we've never had influenza before, never seen it before, and then this year, or this past late 2019, it emerged out of China and went around the world in weeks. And that actually does happen every year. But that's what's happened with this particular virus. However, with influenza, maybe we rush out and we have a vaccine and we get that out to half the population because no more than half the population ever gets vaccinated anyways, unfortunately. But it does have a big effect. And even with that big effect, as of March 19th, we still in the US have 36 million cases of influenza this year, 36 million cases, 370,000 people hospitalized, and 22,000 deaths. And this is a low year. Some years this is 50,000 deaths every single year. So we deal with this. The problem is, it's like we have another flu season on top of this one. As of today, just a reminder, 10,000 total cases and 154 deaths in the US. These numbers are going to go up, no doubt. But This is hitting us every single year. To me, that means we know we do deal with it, we can deal with it, we will deal with it, and we'll get through it. So perspective, most of us will not get really sick. Most of us may get exposed, but most of us will not get really sick. Most of us who do get sick, who get pretty sick, will not be seriously ill. They will not be hospitalized. And for most of those who are seriously ill, they will survive. It is more transmissible than SARS, but it's less fatal than SARS, which is good. SARS had this 10% fatality rate essentially across the board. We are seeing the high-risk groups, yeah, it might be 10%, it might be 15% fatality rate, but for everybody else, that fatality rate is going to be less than 1% when we look at the numbers overall, maybe well below 1%. It is less transmissible than the common cold, but it is more serious. And actually maybe closer to the transmission level of the common cold. We don't know all that yet. There's a lot of clamoring out there. When's the vaccine, and will we get it in weeks or months or years? But how many people didn't get the flu vaccine? We have vaccine for flu. You should still get your flu vaccine. Even if you have it now, we still have flu. Do that. And how many people are out there fighting against vaccines for those fatal diseases that we've forgotten about? Polio and measles and these other ones that are really serious diseases, and we don't take the vaccine there, but we're all clamoring for one here. And likely, if it's only half works and it still causes 10% serious injury, we'd still want to take it because we're worried about this. So we just have to kind of keep these things in mind. Thankfully, this is all happening in the 21st century. We have better science, technology, capability to connect, use resources than we've ever had before. A lot of complaining about a lack of tests. What was done was absolutely remarkable. The technology about making really good tests very quickly and getting those out. Now, we didn't get it out to everybody, but that's not something we could do. But the best of science has been brought to bear and is being used. Action, this is one of my last slides here. You have a role to play in this emergency. Follow those public health guidelines. Now, it sounds boring, but it's absolutely necessary. If you don't, you're actually causing damage to your neighbors and maybe grandparents and the like. Follow the public health guidelines and get others to follow them. Obey quarantine and social distancing recommendations. They really are critical. Do the elbow bump, the foot tap, whatever. If you're meeting close friends, try not to do the close hugging, the kissing, all of that. We've been talking about that now for weeks. That's really important. Have a business plan and a family plan. So businesses, we already know there's a lot shutting down, but if you're open, make sure that you're maintaining good, clean environment, that you have staff and allow people to do telework as much as possible. Everybody's adjusting to this right now, and this is dynamic. But also have a plan for your family. Have 2 to 4 weeks of supplies on hand. The supply chains are still moving, but it's going to be slower. Stores are going to be open fewer hours. Follow what's happening in your community. Have a communication plan, and importantly, help a neighbor, especially if an elderly neighbor. Have food delivered to them so they don't have to go out. In fact, just to reemphasize, it is so critical right now for us to help the less fortunate and the disadvantaged. Before this emergency, they were the less fortunate and the disadvantaged, and they had a harder time with everything. Now, that's amplified manyfold, and these individuals are going to be hurting without our help, and there are ways that we can help. So look for ways to help in your community. And then do something creative in your community. A lot of kids out of school, have your own kids. If you have kids, doing something creative, productive. It's important for their mental health, but it's also can maybe come up with some very clever things to have a more happier community, healthier community. And then my last slide here, it is a little bit of a pitch, but TGen is a nonprofit. We are actively engaged. We are only operating and doing testing because of the good graces of other nonprofits in Arizona, locally and elsewhere, the NARBA Institute, the Flynn Foundation, the Virginia C. Piper Foundation, and now Blue Cross and Blue Shield. Individuals donating money to pay for tests, and then we're working as hard as we can to provide as much support in the overall system as possible. So you can help out as well too. And that's my last commercial, and that's my last slide. So from here, I think we're going to go ahead and move on to questions, and hopefully I'll be able to answer them.
Great, thank you so much. So the first question is from RH, who asks about the Arizona hospital capacity. Could you speak to that?
Thanks. So RH, it's a great question. It is probably one of the things we have to be most concerned about. We know that during the flu season, regularly, hospitals can get close to capacity. And so this is definitely causing a strain on the hospitals. They are trying to adjust by ensuring that they do not have anybody in the hospital that absolutely does not need to be there. So if you are not asked to go to a hospital or not moved over to a hospital, try not to go to a hospital unless you absolutely need to. Look for whatever resources are in your communities that are being stood up. Certainly the hospitals are being hit hard. I don't have the latest numbers of what capacity they're at. The whole goal, let's slow down the spread. It's going to hurt for the next few weeks. But if we can slow down that spread, push this out a little bit longer, the hospitals hopefully can help absorb and adjust.
Thank you. Max Hacker asks, is a mandatory quarantine coming, and when would you expect the U.S. to plateau off?
So both great questions. Is a mandatory quarantine coming? I think we're going to see that in some communities because a lot of this is very community driven. There is national guidelines coming out. There are really smart scientists and epidemiologists who are helping to provide these guidelines, by the way. The states are taking those in and trying to figure out what works best within the state given the current situation. And then the communities within the states are doing that. So in some places where we've had really bad problems, yeah, we'll likely see some of that kind of shelter in place, try to keep everybody from not interacting and going out. And so we may see some of that, there's no doubt. The second part of that question was, when will we see the US epidemic flatten out? That is an unknown. I'm actually hoping that takes a while for the number of cases to really start to drop down, but that flattening that curve I think that's already happening. We're having an effect. It's really hard to measure if we are because we're not doing a test case here. There'll be a lot of great epi modeling studies to let us know, but it's also going to probably lead us into spring and maybe through spring, but as it warms up and in certain communities, we think that the number of transmissions will drop down just like other respiratory viruses. So we think that it'll die off as we get closer to summer anyways. Whether it comes back around, we don't know that yet. This has not happened with these non-human coronaviruses. It's quite likely that this one's with us to stay and may shift down to the southern hemisphere during our summer, that's their winter, and then back up here for our winter. And then maybe soon in the future we'll have vaccines as well to lower the amount of spread.
Kristen Kaufman asks, what do we know about how younger children respond to this? It seems kids aren't getting it as severe and are more vectors. The question comes because her 4-year-old has asthma.
Thank you. So yeah, another great question. There's been a lot of discussion about kids and them likely being at less risk for disease. They are likely not at less risk for infection, and they may actually be, like you mentioned, vectors. They may be able to transmit to others without us even knowing about it. They just have mild symptoms. It looks like they have a runny nose. They may actually be shedding coronavirus. So this is why the order came down about the schools. We don't think kids are at risk for serious disease by and large. There will be some serious cases. Most serious disease is going to be those other groups that I mentioned, but the kids are important to keep healthy and safe as well.
Jennifer Hanley asks, what do you think about the Imperial College report?
Sorry, I need a little more specifics on the Imperial College report to be able to answer that one.
Okay.
It's only because I read about 20 different reports a day and I'm not sure exactly which one, so maybe we get clarification.
Okay, great. Phil Massey asks about the phase 1 vaccine test that is set to be starting in Seattle. How safe do you think that is? How effective may it be?
Yeah, that's a great question. Thankfully, again, 21st century science, we're at a point now where we're actually doing some testing on some vaccines, and there are multiple vaccine projects going on. There's no way for me to judge how safe this one is. The phase 1 trial is essentially where you have a new drug or a new vaccine that you test on healthy people to make sure that it doesn't actually cause harm to an individual. And hopefully all that goes well, and then hopefully it goes to phase 2 where you can actually start testing against people that may be getting sick and preventing disease. We don't know. We're going to be watching that closely. But even if it does work, we still got to know everything looks perfect, and they've done the study in a couple months' time. Doesn't mean people can get the vaccine. Vaccine production is a very logistically difficult process and takes a lot of resources and a lot of time. That time has been sped up again because we're in the modern age, but it's still going to be a while before any vaccines are available.
Andrea Chavez asks if you can get the coronavirus twice. For example, if you've gotten it once, get over it, and then come in contact with an infected person.
Yeah, there's been a few different studies looking at this and some reports that have been passed around about whether or not you could get reinfected with the SARS-CoV-2 virus and what kind of disease would you get. We actually don't know. A study did just come out yesterday that was a study in macaques and understanding if they were infected, can they get reinfected or do they have protective antibody? It turns out, at least in that study, which only went 30 days, there was protective antibody that the macaques could not get reinfected. Now, a macaque is not man. We don't know how that translates, and we don't know what goes beyond 30 days. But at least there's some evidence that there may be some protective antibody. Maybe that's also going to be very useful for us for thinking vaccine. Vaccine may not give us long-lasting antibody. We may need to be redosed multiple times. We don't know, and we don't know if people do get it later on. Do they get sicker than they were before? That happens with some viruses, or maybe it's milder. A lot of things for us to learn.
Great, thank you. George Jacoby asks, is there a test to determine if someone has had coronavirus but doesn't presently have it? And then a second question about what is the evidence that hydroxychloroquine is effective to treat coronavirus?
So the first question is, there are tests being developed now. One of the things that TGen's working on, and I know a lot of others are, getting these serology tests so we can understand, you will have a measure whether or not somebody was infected. This can be absolutely crucial for us understanding this disease as we look backwards. We're trying to understand it now. So we're trying to collect the samples now that are necessary and then have the tests that we can actually look to see what happens to people's immune system when they get infected and after they've been infected so that we could help answer that question. Any questions about treatments? There's no answer right now. There are multiple different studies that are showing that there may be some effect by one treatment, a combination of antivirals that we already use. We don't know yet because it has not been tried on lots of different populations. So when we're doing drug studies, just even initial good information, that's good news, but doesn't necessarily mean anything in the long run until those studies are done on larger populations and people with either different immune systems or different conditions to see if the drug acts the same.
There's some discussion on the comments here about coronavirus in pets, where the World Health Organization says that there was one instance of a dog infected in Hong Kong. Could you clarify your remarks on whether we know if pets can get infected or be carriers and transmit it to people?
Yeah, so there have been several reports, and veterinary epidemiology is not really caught up yet, mostly because it hasn't been, the studies have been focused on humans. But there is evidence that animals, in the few reported cases, it's been canines, dogs, can get infected because their owner was infected and there was that transmission. There's not much evidence that they actually get much disease. I think we had one report of an animal that did pass away that was positive for coronavirus. I don't know if the two are connected or not. We still have a lot to learn there.
Great. Jeff Hall asks about ibuprofen or Advil and its efficacy in treating coronavirus.
Yeah, so the common over-the-counter medications that you take for treating symptoms likely will provide some help for treating those symptoms, but we don't know anything about treating disease. I can't speak to the different painkillers and fever reducers. They're definitely being recommended just to help manage your symptoms, to help increase your comfort while you are sick, as most people are going to be sick enough to take care of themselves at home. And so I don't have a recommendation one way or the other on that. These are, these are studies that are ongoing, and the efficacy of symptom relief with these types of medications hopefully that we'll get some more guidance on that.
And then we have a few questions that relate specifically to our local area. Melissa Dunstan asks, how many test kits are at the Fort Tuthill drive-through station?
Yeah, so and it gets a little bit of confusion about the number of test kits and testing that's out there. So when we see these pop-up drive-through testing stations, they're not testing. What they're doing is sampling. And so what they use is a swab, what we call an NP swab or a nasal pharyngeal swab. That's the one that the doctor uses for a rapid flu test or a strep test. It goes way up through the sinus cavity and through the throat essentially to get a good sample. These are really in short supply. We know that the supply chain is being worked on that, and so every place that has or test kits, the sampling kits right now, it's really just in time. They're trying to order more, so they're very limited, and at any given time, the amount of availability will change. Testing, on the other hand, where they take those samples and take them to a lab like TGen or to the Arizona State Lab or to a LabCorp or Quest Diagnostics or others that are taking samples from these stations, their availability for testing, it varies, but it's all increasing and everybody is standing up. So we're hopefully going to be able to meet the demand within a few weeks. But right now there definitely are shortages, so to be very specific who can be tested and who can't.
Caitlin Olson asks, when were the 4 cases that you mentioned in Coconino County identified?
So we've been testing for the last several days, and the initial reports, there was one of those came out in the newspaper yesterday, and so everything that's being tested now is when cases are being diagnosed, and there will continue to be others found. There's no doubt now that we're looking in our community. So whether it's 1 case or 4 cases or 10 cases, that's only because we're testing those individuals. There's a lot more out there right now.
Drew Puffer asks about the effects of high altitude on symptoms. Here in Flagstaff, we're at about 7,000 feet. So would we expect to have different symptoms from others with coronavirus?
Interesting question. I don't think I can answer that. I don't know that anybody's looked at altitude differences and the effect on symptoms that individuals are having with this particular disease. But it is interesting. It's something I want to check out further on. Thank you.
And compared to the flu and the numbers that you presented, why do we have such a robust response to the coronavirus with such little numbers?
So, can you restate the question? I think I was going to answer that the wrong way.
Sure. The question was with all the numbers presented about the number of cases of the flu in the U.S. each year, why is there so robust a response to the coronavirus?
And I'm guessing the response, you mean the robust response is in people's kind of psychological response and anxiety around that. It's new. This is absolutely normal human behavior. So if you're freaked out about this, that's totally normal. It's what you do with that feeling. You don't want to try to spread that. The fear is absolutely contagion. The fear has moved faster than this virus. And like we say, the virus has moved faster than the regulatory process, that's what sometimes gets in the way of responding. But things are changing, so we're actually able to use more resources now, which hopefully helps lessen the amount of anxiety that individuals have. But you also kind of have to make that conscious decision. It's absolutely normal and natural to be afraid of the new, and something that is deadly. This virus is deadly. There's no doubt about it. Right now, we don't think it's going to be as bad as what the flu is every single year. As far as the total number of deaths in the U.S., because it hasn't been in other places, but it could be. It could be like having just another really, really bad flu season on top of a flu season.
Great. Another commenter asks, how many cases do we need to see in Flagstaff to know that we are flattening the curve?
Good. And I think there was a question also about cases being identified, and really what I should say is positive tests. because again, we don't know the number of cases, and right now we're only starting to learn that there are cases. We knew that. We had a good sense that there was some. Now that we're testing, we're finding it, and that's the same everywhere. The total number of cases that gives us an indication we're flattening the curve. It's really about the percentage of new cases that occur every day. It's not a total number, because we don't know what the total number is going to be. We have to watch, and as you know, right now we're going to see a doubling and maybe a quadrupling of cases as we're doing more testing on a very regular basis. But once that goes down to only a 50% increase in new cases and down to a 10%, that's when we know that we're really starting to have that curve flatten out.
Jennifer Williams asks, should elderly people over 70 get tested if they have one of three symptoms, for example, a cough but no fever?
So right now there are very specific guidelines that are being drafted up and shared, certainly among all healthcare providers in northern Arizona, at least in the Flagstaff region. That's happening in places all over. And so with those types of recommendations, they would be deciding, it depends on the day of the week during this response right now, as we learn more and more about spread. So it could be that elderly individuals that experience symptoms in a place where we know we have circulating virus, doctors may provide an order for that testing. But that's going to be up to that doctor, because they're going to know that patient and whether or not seems like something that's possibly in the realm of coronavirus. So I don't want to say a blanket yes or no. That's definitely a conversation to be had with the healthcare provider as they continue to get guidance daily.
Anya Metcalf asks, where can we find TGen data to keep track of efforts in Coconino County? Is anyone else testing here in Coconino?
So we're working, let me answer that second part. We are working with a large number of healthcare providers. We know that there's a lot of coordination, because there are different places to get testing done. So we're trying to use all those resources. So TGen's testing some, LabCorp's testing some. We know some are being sent to Quest Diagnostics, and others are with the Mayo and others at the state lab. So it wouldn't make sense to only just look at TGen numbers. We're part of that overall response, and the state is tabulating the number of positive test results. And then you'll see a difference between positive and presumptive positive. That just depends on at what stage a lab is in, if they've been certified and now can call their samples positive. And again, that's the positive test, which relates to actually a case, but we don't want to necessarily confuse the two. There's testing going on, and then there's doctors working with their patients and definitely identifying cases.
Great. Joe Lama asks, what was the holdup on widespread testing here, like what has been done in South Korea?
So I'm guessing, Joe, you mean here as in the US versus South Korea. Part of what happened is that the CDC came out with a very good test very early on. And there were some issues with it, and they straightened that out. And of course, that's for everybody to see, and those issues get blown up into giant things. But it didn't change the fact that they still came up with a very accurate test that was then sent out to the state labs across the country to then respond to trying to identify those very first cases, while others are trying to stand up and develop their tests. I can't speak to the South Korean supply chain. We know that there's been some issues, say, with the WHO test, not as accurate as the CDC test. So there's a balance. You try to get as much information, but you also want it to be as accurate as possible. We're probably erring more on the side of accuracy, so we weren't getting out bad information, but also limited the total information we could get. And that's, I think, probably why you see the difference between the two countries.
RH asks, do you think we should be considering repurposing resources to handle the eventual rise in patient needs? For example, can the universities be used for non-COVID cases so hospitals can focus on the outbreak?
Yeah, so for instance, I was on a call with county emergency management here, and I've been working with emergency managers for a long time, and they absolutely have thought these things out and know where all the resources are that can be used for different things. In some cases, you shelter people when there's a natural disaster, and you just need specific resources there. For taking care of patients that are not serious, but shouldn't be clogging up the hospital system. Those are discussions that are being had too. A lot of that is making sure people can take care of each other at home, but certainly other resources are being looked at to provide relief for the healthcare system.
Adam Shimoni asks, can you give us an update on how many tests TGen is producing and how many of those tests are being used here in Coconino versus elsewhere in Arizona?
Adam, I can give you probably more accurate numbers if we talk later offline. We are in the process, so we're doing two things. We're part of the emergency response and we're trying to scale that up. And those are two processes that don't necessarily work well together. So we're doing it in stages. Right now, our laboratory is looking at about 150 tests a day. This week, next week, it'll be double that. The week after that, it'll be double or more than that. So we're trying to scale up to, within the next couple of weeks, to be at a point where we could be doing 1,000 cases a day. And we are working in the overall state's response. So we are not just working with Coconino County. We actually are working with the healthcare providers and public health systems across the state, including interacting with our tribal partners as well to provide support there.
Jennifer Hanley, who had asked before about the Imperial College report, said that the report indicates that we might have multiple bouts of isolation, so 1 month normal, 2 months in isolation, and that this could last for 18 months until a vaccine is available.
Yeah, so this may be the study that was discussing the fact that we could either have significant quarantine and maybe decrease the overall time or use the measures that are happening right now, and we're gonna have to deal with this, a lot of this kind of staying at home, not going to school or work for upwards of 18 months. That's just all based off of statistical modeling, given very specific set of conditions. We don't really know. We don't really know the impact of when we get the summer, the warmer months and coming into summer, which we know stops and slows down viruses in general, or if this will continue to go through the summer, or if it'll come back then after the summer. There's a whole lot of unknowns, and that I think it's interesting and it's useful to do these statistical modeling techniques, but that only gives us ideas. It doesn't tell us actually what's going to happen.
Eli Thompson asks, do we know if those who have had COVID-19 will suffer any long-term health concerns, such as permanent decreased lung capacity? Yeah,
some of the studies coming out of places like China and South Korea, where they've really had significant effect and they're on the downswing, they're starting to look at what actually happened to the body and what's happening with these individuals. Definitely there will be people with long-term lung function impacts. We don't know how many of the people who get pneumonia, if that'll cause long-term issues, or if it's just the people that are on more serious disease but survive. Will they have decreased lung capacity? Most likely we will see that. We can't really estimate what that is. It's going to be different for different parts of the population, and certainly a thing that's being learned right now.
Michael West says that many restaurants and cafes are doing takeout instead of having in the restaurant seating during this time. So how risky is it that coronavirus can be transmitted through food, as we'd all like to support our local businesses?
Yeah, right now the CDC is not giving a ton of information around this right now because we don't totally know. We do know that some surfaces can be contaminated and then you can infect yourself. Could somebody who is actively sick contaminate food that you would then eat? We don't know that a kind of the gastrointestinal route is a way to get infected. We have seen the fact that people can shed the virus in their stool, but that doesn't necessarily mean that they got infected by eating something that was contaminated. That's usually somebody who has an overall infection that probably got infected the normal route. So eating food, we don't really know. There's not great evidence to suggest that that's possible. At this point, we can't rule anything out. We do think that food being prepared in a safe environment, that following the normal structures and rules about handling and preparing food is not likely to end up causing anybody to be exposed to the disease.
Great. Julie Beck asks, can you explain the benefits of physical movements and exercise for immune system function? Of course, here in Flagstaff, we have lots of open air spaces.
Yeah. I don't know that we can say much about specifically exercise helping you ward off getting COVID-19, but exercise is important to stay healthy, and in this case, it is really important for us to stay healthy. So gyms are closing, but that's a great way to get exposed to something because a lot of people handle gym equipment and whatnot. But getting out and getting exercise, I think, is absolutely crucial, both for our physical and our mental health. So I strongly encourage that, just not in large groups of people.
Rose asks about whether testing kits are getting to the indigenous nations in a timely manner.
Yeah, so we've worked with a number of tribal communities, letting them know our resources and understanding how they're getting tested, and they certainly are. I mean, all of the resources that are available to all populations right now. Certainly here in the state, there have been reported cases in the news with the Navajo Nation, and we know that there's a very strong response from a number of entities working with those partners and responding to that, and including test kits being made available from a variety of sources. So yeah, absolutely. The goal is to make sure we got open channels of communication and support between all entities so that we can find out who's in greatest need and provide that support.
Zeep asks, the flu comes back every year. What is the likelihood that COVID-19 will also be a recurring disease?
Yeah, that's a great question. That's the one that we're all kind of waiting for. We're starting to see more cases down in southern hemisphere, and I think that's mostly from travel, but that's going to give us a good indication. Do we really see a lot showing up in their winter? Right now it's their summer. As they come out of that, it starts to cool off. Then do we see a lot of spread? More so than what we're seeing now. That could give us an indication that this will be seasonal, really dictated by the weather, and will it come back? Now, if we get a large amount of immunity from this virus, there's not a lot of room for it to come back, but my guess is we're probably seeing the virus mutate enough too that we may not have long-term immunity to any season's given virus. Again, this is a lot of stuff we don't know yet.
Great. And just a couple more questions here. I know you've got to go and do some more research to get us covered under the testing and whatnot. Astro Bokanon asks, how fast do these virus types mutate or change? Is it possible that a vaccine developed now might not be effective in 18 months because the virus has changed enough?
Yeah, good question. So as an RNA virus, this virus will mutate pretty quickly, and we know that already has been. Those mutations doesn't necessarily mean that it's changing the virus. We don't know, for instance, if any of the circulating strains in the globe are more virulent than others because of those changes. But you get a mutation here and a mutation there, it will start to affect potentially the look and feel of this virus. The point with vaccine makers is they're absolutely looking for ways to develop a vaccine response around those things that don't change, those things that are what we call conserved. Even though we'll see mutations occurring, the vaccine should be developed so that it will adjust, or maybe it has to be adjusted every year, just like with flu. Again, things we'll still need to learn.
And Paul Keim asks, do you know the sensitivity and specificity of testing based upon clinical specimens yet? In particular, how confident are we in negative tests?
Good question. So I think what we're seeing is really high sensitivity and specificity with the standard tests that have been developed. CDC test uses what we call real-time PCR. It's a very sensitive molecular technique that is well understood around the world, and it's what TGen's developed their tests on. It's what everybody's developed their tests on. These tests are likely stable and are continuing to be looked at certainly for sensitivity and specificity. If the virus changes and we start to get more mutations in those regions that the test was built around, those conserved regions, we actually might start to see some testing failure. I think where we see testing failure for diagnosis is actually when we get a sample that doesn't have the virus in it, but maybe a person is infected somewhere, maybe it's so low level that that particular sample didn't have any detectable virus in it. Or you're far enough along in the disease that maybe you were infected, but you're not shedding virus now and the test won't pick it up. Or the other is true, maybe you're too early in the disease because you're doing screening of asymptomatic people that you may not actually detect the virus because it's not there yet and the person could be infected. So that's where testing will collapse.
Great. And more people will watch this after the live stream is done. Where can people go to get their other questions answered?
So as I mentioned, really those trusted sources are going to give a lot of these answers, or you'll be able to find the answers. A lot of the frequently asked question lists at the CDC, Hopkins, a number of other really reputable sources to find that information. TGen, we're going to try to help provide information. We work a lot with our local healthcare providers and public health partners to help get good information out there. And so those are the places really to seek out answers.
Okay, well, thanks so much, Dave. That was really excellent. We really appreciate your time. Thank all of you for joining us, and from all of us here at Lowell Observatory, I hope this has been helpful. Our best wishes to all of you to stay safe, stay healthy, stay smart, and we'll all get through this. Thank you very much for joining us. Hope it's been useful.
Thank you.